Peace. Welcome. What's going on, YouTube? All right. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yes. Peace, YouTube. Here we go. We pick up in the 27th chapter, Clinical Assessment of Venous Return. This is episode 70, and we pick up at page 411. All right, let's do it. Second paragraph, baseline assessment of circulation and perfusion. The unstable cardiopulmonary system requires serial evaluations for assessment of improvement or deterioration. A simple observation or measurement, unless extremely abnormal, is often misleading. The delta factors that occur with time and or therapy are more meaningful and easier to assess in terms of clinical significance. A general clinical evaluation of the circulatory and perfusion status is essential as a baseline, since even the most sophisticated of monitoring systems are of little value unless evaluated in conjunction with the general clinical status. Such an evaluation in critically ill patients must include at least the following. 1. Blood pressure. Mean arterial pressures below 60 millimeters Hg and above 110 millimeters Hg are disturbing. However, even normal blood pressure does not assure adequate flow. The changes that occur or do not occur are more significant. In critically ill patients, routine cuff blood pressure measurements are extremely inaccurate. More accurate and reliable values can be achieved by direct monitoring using an arterial catheter. 2. ECG patterns, rates below 60 per minute or greater than 140 per minute in adults are disturbing, since reserves for increasing cardiac output are limited. The presence of arrhythmias must be observed and evaluated. 3. Peripheral perfusion, skin temperature and color, sensorium, and urine output. And 4. Arterial blood gases. Guidelines for fluid challenge, bottom of page 411 in the 27th chapter. The following is a guideline that we find useful for a fluid challenge principle with pulmonary artery wedge pressures. It is called the 3 to 7 millimeter Hg rule and is correlated with the schema in figure 27.2, which we looked at in the last reading. This is very precise. If you're taking notes, I will make sure I put this in the description as well. Thank you so much. Peace, YouTube. What's going on? Oh, man. Live from the light. It's been a long day. I was at work all day. Wanted to make sure I get on here and bring you to peace. peaceful place on YouTube where we read books and learn from masters. So I'm Master Fitness Trainer Uriel Riley. Thank you for being here. Love to all the book lovers community, to the peaceful part here on YouTube where we read books. All right. Step 1. Obtain general, clinical, and laboratory baselines and measure PWP. Step 2. Give 50 to 200 milliliters of appropriate solution within 10 minutes. Exact volume depends on the clinician's appraisal of the patient's condition. Step 3. Observe the systemic circulation for improvement in blood pressure, peripheral perfusion, and urine output. Re-examine the chest for presence of rales, wheezes, or other advantageous sounds. Adventitious sounds. Step 4. Evaluate change in PWP. If less than 3 millimeters Hg, areas A and B, figure 27.2, repeat process until there is either A, improvement in systemic circulatory function, or B, emergence of adverse chest physical findings. If more than 7 millimeters Hg, area E, figure 27.2, continued volume expansion is not likely to improve venous return. Administer more fluid only if the clinical situation dictates the need for further increase in ventricular preload. If between 3 and 7 millimeters Hg, areas C and D, figure 27.2, wait 10 minutes and again measure PWP to compare with baseline measurement. If increase is now less than 3 millimeters Hg, repeat entire process. If increase remains between 3 and 7 millimeters Hg, repeat entire process, but reduce quantity of fluid challenge. The same guideline may be used with a CVP catheter. It is then the 2 to 5 centimeters H2O rule, i.e., delta P EVP of 2 centimeters H2O and 5 centimeters H2O are used in step 4. The controversy concerning colloid, blood plasma, albumin, dextran versus crystalloid, saline, lactated, ringers, 5% dextrose in water. Administration is beyond the scope of this text. Suffice it to say that the principle of fluid challenge is appropriate irrespective of what solution is deemed advisable for volume expansion. Bottom of page 412. Improving ventricular function. When negative inotropy exists after proper assessment of vascular volume to space relationship, pharmacologic manipulation of the cardiovascular system may be indicated. Such manipulation generally consists of positive inotropic drugs and or diuretic therapy. Isoproterenol. Drugs that will immediately improve myocardial contractility, beta 1 adrenergic stimulators, are titrated in appropriate intravenous solution. The classic beta drug with excellent inotropic and chronotropic increased heart rate effects is isoproterenol. This drug displays a significant incidence of arrhythmia when administered to patients with limited ventricular function. Often, the accompanying peripheral vasodilation results in a drop in systemic blood pressure. Since patients with significant heart disease frequently have partial obstruction of the coronary arteries. This hypotension may further compromise coronary blood flow. Thus, isoproterenol may have an overall detrimental effect on myocardial metabolism, causing a significant increase in oxygen demand while tending to decrease oxygen delivery to the myocardium. Peace, highest heart love. Thank you so much. Awesome. Thank you so much for the likes and subs. We are pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. So we're in the masterful 27th chapter of this great book. Here we go. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yearbook Medical Publishers, 1979. We get to see how we got to where we are now and the information that they used then to be precise in helping people with their respiratory care. So thank you so much for all the book lovers and readers and writers. We love you all. All. Thank you so much. All right. Here we go. Middle of page 413. Dopamine. Dopamine is naturally occurring catecholamine and precursor of norepinephrine and epinephrine. It has most of the beneficial properties of isoproterenol while possessing fewer of the disadvantages. At lower infusion rates, 1 to 2 kg per minute, a direct dopaminergic, dopaminergic, yeah, effect results in renal and splanchnic vasodilation. Yikes. This may increase renal blood flow. At infusion rates of 3 to 10 kg per minute, adreneric effects of positive chronotropism and positive inotropism are added. However, the increase in heart rate is generally not as excessive as with isoproterenol, and the tendency toward arrhythmias is not as prominent as with isoproterenol. Continued increases in dopamine dosage greater than 10 to 15 kg per minute cause the alpha adrenergic, yes, I keep doing that, effects to become predominant. The resulting vasoconstriction will frequently lead to a decrease in cardiac and renal output. Thus, the general advantages of dopamine compared to isoproterenol are: 1. Less significant tachycardia. 2. Less oxygen demand on the heart. And 3. Decreased potential for development of arrhythmias. That's really good. Guess that's why they use dopamine so much, right? Diuretic therapy. The decrease in cardiac output that accompanies heart failure causes renal hypoperfusion, which results in sodium and water retention. This salt and water retention leads to increased venous pressure and causes transudation of water and salt to the interstitial space. Thus, total body water and sodium are increased. The aim of diuretic therapy is to achieve a net loss of sodium and its associated water. A potent diuretic, such as furosemide or Lasix, is a very effective agent in this circumstance because of its: 1. Prompt onset of action. 2. Inhibition of sodium and chloride transport back into the circulation. And 3. Effectiveness irrespective of the acid base status. Furosemide is also a direct venous dilator. An initial dose of 5 to 20 milligrams given intravenously is followed by waiting an appropriate time interval, approximately 30 minutes to 1 hour, for assessment of its effects. Increasing doses are administered when indicated. Often, the patient will recover a significant amount of cardiovascular function as fluid is lost. And the preload is adjusted downward to a more appropriate range. However, many patients require a positive inotropic agent to be incorporated into the regimen, either primarily or as an adjunct to diuretic therapy. Airway dynamics and atrial pressures. Transmural atrial pressure, intraatrial pressure minus intrapleural pressure, is a function of intraatrial blood volume. When intrapleural pressure is normal and consistent, changes in atrial pressure are directly reflective of changes in venous return following fluid administration. However, when intrapleural pressures are manipulated, atrial pressures must be considered in relation to intrapleural pressure. Ding! Have to drop a pin right there. You have to look at that. You have to. You have to consider in relation to the intrapleural pressure. Mhm. For example, when intrapleural pressures are significantly increased, any increase in atrial pressure is not directly reflective of changes in venous return. In fact, under these circumstances, the venous return is often greatly diminished, leading to inadequate ventricular filling. Since reliable intrapleural pressure measurements are not readily available at present, estimations of the effects of airway pressure therapy on pleural pressures must be applied. Airway pressure to intrapleural pressure relationship. With spontaneous ventilation, see figure 21.2, 6 chapters ago. The intrapleural pressure during inspiration must be less than airway pressure. Normally, the transpulmonary pressure gradient is small, 2 to 10 centimeters H2O. As in airway resistance increases or lung compliance decreases, the transpulmonary pressure, or TPP, gradient must increase in order for the patient to achieve the same tidal volume. When severe pulmonary pathology exists, the inspiratory TPP gradient may be as high as 50 to 60 centimeters H2O. During passive expiration, the intrapleural pressure returns to resting values. Therefore, in most circumstances, when lung pathology is present, spontaneous ventilation results in mean intrapleural pressures being more subatmospheric than normal, an obvious advantage for venous return. Airway pressure therapy always results in increased mean airway pressures that must be transmitted to the intrapleural space to some degree. The degree of transmission varies primarily with lung compliance and secondarily with pulmonary resistance. Control mode IPPV. See figure 22.1, which we looked at a while ago. Peace, highest heart love, YouTube. Thank you so much for being here and reading with us. Clinical application of respiratory care. And we are now in the 27th chapter. So, page 415 at the top. With normal lungs, IPPV control mode increases the mean airway pressure, 5 to 10 centimeters H2O. The major variant affecting mean airway pressure is the expiratory time. Mean intrapleural pressures are believed to be affected to the same degree as mean airway pressures. When increased airway resistance is present, greater positive pressure is required to deliver the same tidal volume. Some of this increased airway pressure is believed transmitted to the pleural space. When lung compliance is acutely decreased, much greater airway pressures are required for tidal volume delivery, but relatively little of this increased airway pressure is believed transmitted to the pleural space. However, when chest wall compliance is decreased, higher airway pressures are required to deliver the tidal volume, and most of this will be transmitted to the pleural space. This occurs clinically every time a patient fights the ventilator. That's why we want to keep checking on them, right? Respiratory care. We don't want them to fight the ventilators, the CPAP machines that we have now in place. Actually, uh, they account for this. We've come so far, right? Oh my goodness! Look, we're at page 415. Highest heart lung. An advantage to having an IMV circuit in line with control mode ventilation is that any attempts to breathe around or between ventilator breaths will result in lower intraoral pressures. Theoretically, this is a cardiovascular advantage as long as the energy expenditure involved is not detrimental and the efforts do not result in fighting the ventilator or decreasing chest wall distensibility. All right, augmented mode IPPV. The less IPPV required, the lower are the mean airway and intrapleural pressures. Inspiratory hold. With normal lungs, the mean airway and intrapleural pressures are increased. When airway resistance is increased, the mean intrapleural pressure will be increased to a lesser degree than mean airway pressure. Retard with IPPV. Intrapleural pressures are minimally affected when retard is appropriately applied for airway resistance. PEEP. Of all positive airway pressure maneuvers, PEEP has the greatest effect on mean airway pressure. With normal lungs, there will be a significant transmission of increased pressure to the pleural space, as great as 90% of the increased airway pressure. With acutely decreased lung compliance, transmission of increased airway pressures appears proportional to the degree of decreased lung compliance. When PEEP is appropriately applied in usual therapeutic ranges, 10 to 30 centimeters H2O, to such lungs, it is doubtful that more than 40% of the increased mean airway pressure is transmitted to the pleural space. Suggestions for interpretation of atrial pressures in conjunction with airway pressure therapy. All right, this is a lot here. Here we go. Let's do it. We have the ability to do it. Let's do it. Suggestions for interpretation of atrial pressures in conjunction with airway pressure therapy. 1. Attempt to estimate mean intrapleural pressure. The normal mean intrapleural pressure is spontaneous breathing is estimated to be minus 5 centimeters H2O. A. Appropriate control mode IPPV is estimated to increase mean intrapleural pressure 5 centimeters H2O. B. 1/3 of appropriate PEEP therapy is estimated to be transmitted to the pleural space. 2. Transform atrial pressure readings to estimated atrial transmural pressures. For example, if normal CVP is 10 centimeters H2O, normal right atrial transmural pressure is 15 centimeters H2O. 10 and then minus parentheses -5 equals plus 15. Simple algebraic problem, right? A, with IPPV control mode, a CVP of 15 centimeters H2O probably represents an atrial transmural pressure of 15 centimeters H2O since mean intrapleural pressure is close to zero. In other words, a CVP of 15 centimeters H2O on control mode probably represents the same transmural pressure as a CVP of 10 centimeters H2O in a spontaneously breathing patient. 2. With CPAP of 20 centimeters H2O, a CVP of 17 to 18 centimeters H2O is estimated to reflect an atrial transmural pressure of about 15 centimeters H2O. All right, 17 minus plus 2 equals 15. Yes. All right. So since a third of PEEP, about 7 centimeters H2O is transmitted and increases mean intrapleural pressure from -5 to +2. Remember, these are only suggestions to help interpret absolute values and to make comparisons when airway pressures are changed. The delta factors remain paramount. For PWP measurements, 1 millimeter Hg equals 0.75 centimeters H2O, assuming that normal intrapleural pressures is a mean of -3 millimeters Hg, and that a normal PWP is 10 millimeters Hg. Normal atrial transmural pressure is 13 millimeters Hg, 16 centimeters H2O. One with control mode IPPV, a PWP of 13 millimeters Hg would represent a normal atrial transmural pressure of, yeah, yeah, pressure. 2 with 20 centimeters H2O PEEP, 15 millimeters Hg, and a PWP of approximately 15 millimeters Hg would reflect an atrial transmural pressure of 10 millimeters Hg. Thank you so much. We're reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, Yearbook Medical Publishers, 1979. To all the aspiring rep techs and med techs, OR techs, anyone in the respiratory care business, or expanding their information and knowledge to take the MCAT. Thank you so much for being here and reading with us, all the book lovers and reading masters out there. We we love you here. We're a part of the book lovers community. So we're at the bottom of page 416 of this masterful respiratory care book. Reading to the people for free here live from the light in LA on YouTube. All right. For PWP, yeah. All right. 3. Take measurement at the end of exhalation, regardless of ventilatory pattern or types of airway pressure support. 4. Do not remove the airway pressure therapy from the patient to measure atrial pressure. A. Proper venous return and ventricular preload must be maintained with airway pressure therapy. Therefore, measurement must be made with airway pressure therapy. B. In general, When IPPV and PEEP therapy are appropriately applied, changes in atrial pressure readings are not significant when therapy is removed. And C, unless adequate time, more than 30 to 45 seconds, is allowed for new steady state equilibration. Atrial pressure readings are unreliable off airway pressure support. The patient with pulmonary summary. The patient with pulmonary decompensation is generally manifesting an increased cardiac output. When airway pressure therapy is instituted to prevent or reverse pulmonary decompensation, the cardiovascular system is placed at a potential disadvantage. The increased mean intrapleural pressures frequently result in increased atrial pressures, but not necessarily in decreased venous return. To increase venous return, the venous system must respond by increasing its venotone. This can be minimized by proper assessment and support of the vascular volume to the vascular space relationship. Many critically ill patients are overloaded in terms of total body fluid, but have inadequate intravascular volumes and compensate by decreasing the vascular space. In these circumstances, airway pressure therapy must cause profound decreases in venous return capability. Mm, mm, mm. For example, the initiation of ventilator therapy usually results in an elevation of mean intrapleural pressure, which tends to impede venous return and ventricular preload. Agents frequently used to allow appropriate application of airway pressure therapy, such as morphine, sedatives, and tranquilizers, may alter the venous tone and contribute to relative hypovolemia. Furthermore, normalization of arterial blood gases, improved arterial oxygen tension, diminished carbon dioxide tension, improved acid base status may lead to a significant reduction in the endogenous catecholamines, which results in decreased venous tone. The respiratory care practitioner, nurse, specialist, and physician must properly evaluate vascular volume to vascular space relationships when instituting and maintaining airway pressure support. The patient's well-being depends on the ability of the team to function smoothly. Teamwork makes the dream work, right? Something we always say at the grocery giveaway, which we have coming up tomorrow. Amazing. Every week. So we're going to have to increase the Venus return, if you will, because of so many displaced. So that's what we do. Help the people. That's what light workers, that's what we're here for. That's what this channel is for. That's what we give love to all the people in our life, right? All right, here we go. Ventricular afterload. Ventricular afterload is defined as the forces impeding flow out of the ventricle. The greater impedance, the greater the energy required to achieve a given stroke volume. If the ventricle is unable to eject blood adequately because it cannot generate the required energy, decreasing the afterload will reduce the energy required to eject the blood, and therefore ventricular output can be increased. In the absence of anatomic outflow, tract abnormality or valvular disease, muscle hypertrophy. The major impedance to flow is the peripheral vascular resistance. The use of peripheral vasodilating agents has recently become significant in the armamentarium of pharmacologic support for the patient with limited cardiovascular reserves. The basic premise is to reduce systemic arterial blood pressure or reduced afterload so that the cardiac output may be maintained while reducing the work of the left ventricle. This technique is particularly effective in patients with limited cardiovascular reserves who manifest hypertension. Sodium nitroprusside or nipride is a direct fast acting and potent vascular smooth muscle dilator. Its rapid onset of action and metabolism allow excellent moment to moment control with intravenous infusion. The primary disadvantage of sodium nitroprusside is that large amounts of the drug may result in toxic blood levels of cyanide. A major disadvantage to the pharmacologic reduction of afterload is that coronary blood flow is decreased because diastolic pressure is lowered. The counterpulsating aortic balloon device is designed to overcome this disadvantage, since it allows reduction in ventricular afterload while augmenting aortic root diastolic pressure. The success of this device, except in cardiac surgical candidates or early postoperative cardiac surgical patients, has been disappointing. We did it. Woo! Completion of chapter 27. We did it. On this 70th episode of Clinical Application of Respiratory Care. We did it. All right. So when we reconvene, we will pick up in chapter 28. Thank you so much for reading books with us. Love to all our friends and family. Love to all those watching the World Series. Go Dodgers. Yeah, we're doing it. For the people, always for the people. Shaking it up on YouTube, reading books, clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel. We're doing it. Highest heart love. Peace, everyone. Love to all those that liked and subscribed. Woo! Doing it. We're doing it. Reading to the people. Now let's have a glass of love water, you say? I love you. So grateful and thankful. All I have now and all that's coming to me. Thank you so much. Mm. I love you. I love you. I love you. It's nothing like love, right? Peace. So much love. So much love. Thank you so much for shaking it up with us. Hey. Yeah, we completed another chapter. Thank you so much for being here and reading with us. Love to all my friends and family. I love you so much, Eagle, Sunflower, Wolf. We're doing it. I told you we're going to read another medical book and we're completing it. So much love. I know. I got to show the way, you know. I know it's super tough vocabulary, but that's what I always promised my daughter, that I would show the way. That's what I use my platforms for. So you'll see, I will put it in the description, the vocabulary, and also on this channel, you can go scroll down and see all the different books that we've already completed. And you can just tap on the playlist and it'll start reading the entire book with you. So yeah, that's what we're doing. Hi, it's Heart Love. Thank you so much. I love you. I love you. And you know it. 'Cause I love myself. Hi, it's Heart Love and Honor. I will see you soon. Peace, peace.